You're listening to episode 46, a conversation about pediatric pain on the Child Life On Call podcast. Hi, and welcome to the Child Life On Call podcast. When your child is sick, the whole world seems to stop in its tracks. Plans and priorities change, and your number one job becomes figuring out how to get your child well again. For some of us, rest, medications, and relaxation can do the trick. But for others, it takes more. It takes countless doctor appointments, invasive medical testing, therapy, surgeries, the list goes on, and then you still may not have all of the answers or results you were hoping for. This podcast features parents of children that have an illness or medical condition and gives them a place to share their own journeys and experiences. We will talk about the ups and the downs, the highs and the lows, but one thing seems to remain the same. Children are resilient and teach us more about ourselves and the world than we could ever imagine. Thank you so much for lending a listening ear and opening up your heart to these families and this podcast. I'm your host, Katie Taylor. Hi, and welcome to the Child Life On Call podcast. I'm your host, Katie Taylor, certified child life specialist. This is a bit of a fun episode because it's not our normal Katie interviewing a parent situation, which we love, and we love to share those episodes. But today is something a little bit special because September is Pain Awareness Month. So today I have with us Jamie Gentili, who you've heard on the podcast before, and some of our top 5 about Cardiac Month. And also she shared her personal story with her mom, which was a really interesting and very cool episode back. I think it was episode 7 or 8. And she is the director of Child Life Services for Inova Children's Hospital in Northern Virginia. And we also have Jody Thomas here, Dr. Jody Thomas, very cool to have you on. You're a licensed clinical psychologist and also the founder and executive director for the Meg Foundation for Pain. So very honored to have you here today. And Jamie and Jody, and I guess I need a J name. Just call me Jenny for the rest of the podcast.
Okay,
So,
Jenny.
Jamie and Jody and Jenny, and we're all here to talk about children's experiences with pain and how we can support families going through that. So I'm so glad y'all are here today.
Thanks for having us.
Yes.
Thanks, Katie.
Yeah.
We're happy to be here. So this is one of those things where I've been lucky enough to work with each of you individually and know you both for a very long time individually. And then it culminated into this. Katie has an amazing podcast. Jody's a genius. It's Pain Management Month. Let's do this. So I'm so excited that we can chat today. I've learned so much about pain management since I began working with Meg Foundation, and have gotten to know a little bit more about the ins and outs of it, in addition to kind of what we do every day in child life, but getting to work with Jody and opening my eyes up to a lot of additional stuff that I didn't realize was out there. It has been really cool. And it just makes me even more motivated to get the word out to families, to make changes where I work, to make sure that we're doing everything we can to manage pain. So I think what we've talked a lot about is that there are so many misconceptions when it comes to kids and pain. And one of the things that I want us to be able to chat about today are some of those things that, and Jody, you're the expert here. So kind of going into what are some of the main misconceptions that people have when they think about kids and pain.
Well, I think the biggest one, and that we talk about all the time with the foundation, and the foundation was really designed and developed because of this very issue, because of the misconceptions and the fact that, frankly, kids hurt when they don't have to. And I think that's dumb, just literally the title of our first blog post for the foundation. And so having worked in the world of pain for many, many years, and so I developed and ran the Pediatric pain rehab program at Stanford and do a lot of work with them, and got very interested in how we can kind of leverage technology and things like podcasts and these things to get out the word out of why we can kind of close that gap, which is about a 30+ year gap between what the research tells us about pain and what actually happens. And when we were going through this process of where are the barriers, because obviously like no medical providers who work with kids want kids to hurt. Like clearly that is not on our list of barriers. But one of the massive, huge primary ones that we are looking to address is the fact that people often see kids' pain, particularly on things like procedures, as just a necessary evil. It just has to happen. There isn't another way to have it happen. That for providers, for parents, and for kids, there's this conception that we have to do it. So that is kind of our game one. And that's enormously frustrating, I think, to us in the biz, as they say, to be like, no, actually it doesn't. There are some really simple and cost-effective and effective and empowering ways for kids not to have to hurt. Now, when working with various medical staffs in different settings, and I've worked in hospitals and places like that for over 20 years now, the also thing we find that really gets in the way on the provider end is the fact that they often don't believe or don't see the fact that there's major implications to this, right? This isn't about the tough few minutes. And this is what I end up talking to people a lot, is that it's a lot more than a kid. They're like, well, is it really that big of a deal that the kid freaked out and cried during the needle poke? And you're like, well, actually it is. One, of course, I think we should all go along the idea that we don't want kids to hurt when they don't have to. But very much the idea that we do not want these kids developing fear of the doctor, fear of medical care, to become that kid that starts crying the moment they pull into the parking lot at the pediatrician's office. Because what we do know is that becomes a really big thing ongoing. This is where in the shorter term, kids start wanting to avoid. They don't want to do healthcare. They don't want to go to the doc when they have the sore throat. They don't want to do those. They don't want to do the preventative care. And really frightening, we actually know from the research that parents start making medical decisions based on the fear of that freak out rather than what's best for their kid. Mm-hmm. And so that gets pretty scary. We know about 1 in 10 parents will actually list pain as the reason they don't want to get a vaccination. So actually has nothing to do with the vaccination debate whatsoever. It's just about the fear of that pain and freak out. That's almost 5.5 million kids in the US alone. It's a lot of kids. And then we see them grow up, and all of us can think of that person, an adult in our lives or multiple adults in our lives who like to say things like, oh, I don't do doctors. Mm-hmm. I don't do that. Mm-hmm. And I'm often looking at, okay, a pretty darn healthy 35-year-old going, well, that at some point that coping strategy is going to not work so often. Yeah. Right. Like this isn't going to go so well. And in this time of COVID and the pandemic, ever has that seemed more apparent, right? We do really need people going and get flu shots this year. When there is a vaccine, that's going to be a thing. So we really are not only setting the stage for these procedures, but all of them to come. And so those conceptions of it's not a big deal, it's inevitable, and there's no way around it are two really, really big ones. And then the ones that, if you want to, we can kind of get to around like providers is like misconceptions about the techniques themselves. Like if we put on topical anesthetic, then we have vasoconstriction. The veins get too small to do the procedure, which is really not true. So the various techniques we use, then there's some misconceptions about that, or really misconceptions about things like we can use comfort positioning to keep kids safe and that we don't need to be holding them down for them to be safe. And as a matter of fact, huge evidence in the other direction. Do not hold those kids down. Super bad idea.
Yeah.
But those are the myths that persist that really get in our way.
Yeah.
As you're talking, I'm just thinking about personal experience, and my daughter has had a recurrent UTI. And so after her first one, they mentioned like we should go get a VCUG. And if I weren't in the medical field to know exactly what a VCUG, what if I just called and scheduled it and we went in and then we were there and I had to go through with it? But I'm like, no, I'm not going to have my daughter go through this very traumatic and painful experience at just 2 years old after one UTI. But I'm just so thankful I knew to say no or to ask more questions and say, can we try something else first? And they're like, sure, let's do an ultrasound first. I'm like, well, that's way better.
Yeah.
But, it changed the way I want to give my child care. Maybe she really does need a VCUG, but I don't want her to go through that pain. So you're exactly right that it affects medical decisions.
Yeah.
And those are the things we don't know about, right?
Right.
Mm-hmm. And the things that you mentioned before, I just see clear examples of it every day because no one goes into healthcare to inflict pain or to hurt people. They don't do it because they're terrible people. They want to help. They want to be the helpers. And especially people that work with kids, they want to make kids feel better. They don't want to inflict more pain. So it's not, when we see poor pain management, it's hardly ever, probably never because of someone just not caring. But this is just 5 seconds. It'll take 20 seconds start to finish, literally. And then we'll be on with our day. And the number of times we hear that, and we have to go back to what you were saying earlier, Jody, of this is 20 seconds to you, and then you're on with your day, but it actually has a vast effect on these kids, potentially the rest of their lives. And I've seen this when I've worked with kids who have done really well with procedures and have a good coping plan in place, and we follow their coping plan and it goes great. And they've been in the hospital for a really long time. It's going well. And then they get one experience with a poorly executed or not executed coping plan, and they're back at square one. And so that's impacting every single poke and procedure after that. And it really has a lifelong effects. And I can certainly speak to that. And I won't tell a ton of personal stories, even though it is my favorite thing to talk about is myself. But those times when I was a kid going through the medical world, back in the day that we didn't have the best pain management. And I remember those days like they were yesterday. Yeah. And they have a deep impact on how I went through medical care as a kid. And the fact that I still remember them like they were yesterday today is a lifelong impact. So I was, one of my huge stressors as a kid was shots. I did fairly well with blood draws, but shots, vaccinations, and IVs were my two huge stressors, to the point where I once passed out in the doctor's office before the nurse even came in to give me the shot because I was just so freaked out about it.
And Jane, that's what speaks so good of how much it's not. I love having the pup.
Is it Lucy or
can
Pip?
You call her? Sorry. Oh my gosh.
But it speaks to the fact of how big this is. It's not about those 20 seconds. Like you passed out before anyone was even in the room, right? Thing. And we talk about kind of one of those other myths that I think, especially for the parents in your audience, Katie, is the myth that we as parents can't have a voice, that we are going to make them too mad or irritating. When we were really going through what we call the design thinking process, as we're designing interventions, and where are the barriers? The biggest barriers that we found is that parents felt like they couldn't have a voice in that setting, that they weren't allowed to speak up. They couldn't, Katie, like you did, like question, is the VCUG something we need to do first? And or be able to, like, when their kid's coping plan isn't being listened to know that they can stop and say, look, we're doing the topical anesthetic, or we're going to have them come and sit in my lap. And no, I'm not going to leave the room. I am going to stay here. That we do have that voice to walk away. Like one of the stories that I've worked in hospital settings and I've been doing pain work for 20 plus years. And when my daughter was born, she ended up in the NICU. And this was really kind of one of those big things that motivated me to found the MEG Foundation and kind of gather the forces of the pain world and the tech world and the design world together was, and again, I know the world, the preemies, and I know all the research, and that if we were doing painful procedures, particularly on newborns and preemies, without adequate pain management, we're literally damaging their not yet fully cooked neurological system. And at that time, I was running a chronic pain rehab program. And, most of those kids have had traumatic pain experiences right after birth. And I'm like, okay, well, not doing this. And I'm faculty at the med school that is running the NICU that I am in, where I work in the pain program. And the tech comes up to do a heel stick on her for a blood draw. And I asked him, I said, okay, or do you want me to hold her and do skin to skin and breastfeed? Or do you want to go get a glucose pacifier? And he looks at me and says, oh, we don't do it that way here.
Yeah.
And my poor
Bad
husband,
answer.
who like knows enough, is like, oh gosh, what's going to happen?
Oh God.
Because he knows that I am not the shy and retiring soul under the best of circumstances, let alone when I'm sleep deprived with my kid in an NICU and postpartum. And I looked at him and I said, yeah, well, it is now. Like, we're going to do that.
Yeah.
And he said to me, he goes, well, that's not convenient.
Oh no.
And I have in my head like this movie montage of all the research and all the kids I've seen and all of this. And I said, okay, I'm going to pause for a moment with you, sir.
Yeah.
I'm going to reflect back what you just said to me. So first of all, it is not inconvenient for you to walk 10 steps and get a glucose pacifier, nor is it inconvenient to give me 20 seconds to get her out of the isolette and hold her. Like, neither one of those things is convenient. And if that's too hard, I will go get it for you. That's fine. I will do it.
Give me the code.
Even if it were inconvenient, even if it were, you just told me that you're willing to hurt and possibly permanently damage my baby because it's inconvenient.
Right.
And again, it's kind of back thinking, he's like, oh my gosh, I didn't mean that. I'm like, I know you didn't mean that. That's why we're still having this conversation.
Right.
I need you to know that's what you just said. And
Jody, has that man ever been seen again?
I do. I think about that man who I'm sure had a very rough day. Because I said to him, I said, look, I understand that you don't have the protocols in place to do what you're supposed to do. You haven't been trained. I get that. And believe me, by the end of this day, I'm going to have a series of conversations with people that are going to guarantee this isn't going to happen to my kid again. But I can't let the fact that you don't know what you're doing hurt my baby. And that was in that moment of looking around that NICU of all these other parents, all these other people. And I'm in my home turf. I've worked in NICUs. I've been here. And I have to fight this hard. And that was really that part of being like, we need to give parents a voice and we need to empower them. Yeah. These other parents didn't know how to fight, what to fight for, or that it was okay to fight. And that's what we need parents to have. So it's not whether or not they happen to have the person who's following the good coping plan, that they feel like they can make sure that their kid has as good of an experience as possible, no matter who's on the other end. Because again, I knew this guy did not, he works in a NICU. He was clearly a good guy. Okay.
Yeah, exactly. Well,
he's not a bad
I have a question for you, Jody. I'm thinking so for those exhausted parents who cannot think straight and they're watching their child in pain, what are what some of the top 3 things you would have a parent consider? And even if they don't want to talk to staff, because sometimes it's hard to just say, I want to do this, but what are 3 things they can do for their child that will immediately or support them in the long term?
So there's a couple different things. So one, the other thing is we actually are designing and have designed, we have some tools coming out through the Meg Foundation that are designed to do exactly that. Like knowing that it is exhausting and we're stressed. Like this is no one. I mean, certainly I wasn't at the top of my game standing in the NICU. Okay.
Right.
Every parent in this situation is really stressed. So we're about to launch a tool that actually you can put in the email address of your doctor or the institution, and we send them what the best practice guidelines should be. So we can change that power dynamic from I am the parent who's being a pain in the butt and difficult to why aren't you following the recommendations of the World Health Organization, the American Academy of Pediatrics, and literally every pediatric organization in the world? We've changed the dynamic of that conversation, right? And when we're like, I want you to use topical anesthetic, they're like, that's not important. You're like, actually, it's the number 1 recommendation that everyone put forth. And so it's super weird that you're not doing that.
Yeah.
So we want to be able to empower those parents who, again, are exhausted and tired. And in that same tool, we're having what we call speak up scripts. These are exactly the words that you could say to this provider to ask for this. This is how we can talk to our kids in what we call comfort talk, which is really sort of this therapeutic, hypnotic language. But I think the top 3 things we do are just the power of human touch and that connection and how regulating that is in like every circumstance, right? We literally change our pain receptors, we change our brain chemistry, we change it all. And if I were going to pick like one thing that should always happen, it's that.
Okay.
Yes, topical anesthetic. Yes, those things, but we don't always get the amount of control we want over that, right?
Right.
If we're sitting there, and again, we're putting together tools like, hey, ask for it. And if they won't, here's a pop-up that can tell you 3 places within a mile. You could go send someone to buy the topical anesthetic.
Oh, yes.
It's
amazing.
So
Isn't that great?
Solutions to that. And breath and breathing. And as can we talk about a lot, like it's so hard because when our babies are threatened, this is when our anxiety goes up. But we also know that the biggest predictor of a kid's distress is the parent's distress. And so the more we can bring ourselves into our bodies and to calm ourselves, and that is a tall order. Like I say that with no, like not as like, oh, just take a few breaths and calm down, because that feels so dismissive. I think when we're in that moment, I do not say it in a way that I think it's easy. It's one of those things that's simple, but not easy to do.
Yeah.
Right.
But being able to center ourselves, and also the thing, especially when it comes to procedures, is knowing that we can always say not yet. You know, we often get in that, and this is something I tell when I train staff all the time, when we realize things have kind of gone off the rails, right? Like everyone's too amped up, everyone's too upset. I'm like, we can always sit there and say, stop.
Yeah.
Go do something else and then come back and do this. Like at some point when we're at, Mach 10, this is not going to go well. And then there's very few circumstances that are actually life or death threatening, that it has to happen in the next 10 minutes. Like maybe it needs to happen today or in the next few hours, but then everyone go. Let's group. Let's everyone calm. I mean, and every parent knows like that whole idea of like this timeout, this one's for me. Okay, this one's so I right? Like, and when we're reaching that in those medical settings, to know, be like, go do the next kid, then come back to us. We'll wait longer. This is going to be better for everyone if we can do that. If we can take the temperature down in the room, take the stimulation away, and allow a kid to focus just on what is going to be good and therapeutic for them to focus on.
Yeah. And that's such a good point. I have a really good example of that from my own experience, and I promise I'm going to stop talking about myself. But
you said that last time.
You should know by now that I will never stop talking about myself. No, but when I was getting treatment at NIH, they were trying to start an IV, and that was one of my huge stressors, like I said before. And we didn't have, we had LMX or EMLA at the time on one site, but we couldn't get it. And they tried right on my wrist. And for some, like that particular part of my body for me was just, my brain was like, nope. And they tried it. And I basically like went into a panic seizure, and it was terrible, awful, ridiculous. They couldn't get the IV. The nurse, there were a couple of nurses involved at that time, and the nurse was like, okay, let's just try one more time. I see one on your hand. And one of the other nurses, who was just my little angel and saving grace, and who probably saved the staff from my mom several times throughout her career, she jumped in and she's like, no guys, like we don't need to get this right now. We can wait. Let's get settled. Let's regroup. And the next time they tried, it was a couple hours later. I was in a different room. I had music that I listened to, and they got it on the first try. And it was a complete 180. It was just a change of environment. But they really like had to, instead of just plowing forward. And it's almost like, no, I can do it. No, I can do it. It's not about if you can do it or not.
It's not about
That's
you.
not what this is about anymore. This is about taking a break and realizing that we can come at this in a different way.
Yeah.
And I think that and Jody, we've talked a little bit about the psychology behind changing your behavior. And I think that's one of the things that really trips medical professionals up, is that they don't want to fail, and they don't want to walk out of that room without a successful cannulation. And that's to them as failure, when that shouldn't be considered failure if they're giving that kid the break that they need.
Yeah. Well,
Right.
it's that redefinition of what we mean by success. Like, okay, is it in? Great. Is this kid going to scream every time they see you now? Have you made it where this
Is that success?
is that success? Like, how are we
Yeah.
Right.
And that's where, for as a parent too, to be like, look, you know, to me, it was this conversation that when I first started working in this field, you know, in the mid 90s, this was when all of a sudden we were seeing these bigger survival rates with cancer and with HIV in kids and with all these things, which was great. But now I'm like, guys, alive is a good thing, but not the standard we want to aspire to as our end goal, right? Like, we want to get to the other end of this not traumatized and not, you're like, yes, alive, but I think we can go bigger. Like, let's go higher for this as our goal. And in that way of having to redefine our success, and as a parent going, and look, I want my kid to get their procedure done or get the IV started, but I want them to feel comfortable and powerful and in control, because and especially for our parents with chronic illness, you're like, this is going to happen a lot. So this isn't even maybe a yearly or twice yearly freak out with a flu shot or an immunization or what, which is a problem in and of itself, believe me. But we've just opened up opportunities for that to be, it's what it becomes. And what you're describing, Jamie, in your story is that was either a potential for re-traumatization, for solidifying that trauma, or what you got instead by stopping, allowing you to calm, allowing your body to physiologically calm, allowing everyone else, is that became a master experience. That became a success story. That became a counter to your trauma as a reinforcement. And that's when we're redefining of like, they're going to be mad at me if we don't start this. And you're like, my favorite research to quote to families that I work with is that the patients in hospitals who get the best care are the ones that are often rated as the biggest pain by staff.
Yeah.
And I'm like,
it's true.
Go right ahead.
It's true.
You're like, they don't like me very much. And I'm like, we don't want to be disrespectful. We don't be rude. We want to be kind. Like, that's not, clearly that's not it.
Yeah.
But using your voice to break the train of whatever's going on, like being the one being like, no, we're done now. And we're gonna get off the train and we're all going to get back on in a calm and orderly fashion in a little while.
It's so true. And that goes away in so much of what we think in just like normal human society of just like, go along with it. Don't cause any problems. And certainly in the power differential of being in the healthcare setting where the medical staff is in charge, quote unquote, and you just got to do what they say. And that whole concept of standing up and saying no and not worrying if people are going to and this is something that I tell the child life specialists that I work with all the time of, sometimes those conversations are going to be icky and you're going to have discordant talks with people and it's going to be tense, and that means you're doing your job.
That means you're doing it
your
right.
Job. Yeah. It's your job to say, hey, this needs to change, or this needs to be done differently, or let's try this.
Yeah.
I think a lot about some of the parents that are listening to you, Jody and Jamie, talk about these painful experiences that their kids are having. Maybe they didn't know to advocate for the topical anesthetic or to even be held during something. And, but I love what you said about the counter experience, right? So now moving forward, what has happened, but moving forward, we can start to advocate, start to initiate these things, which can kind of not omit the past, but, work toward a better future. And I'm just wondering what other things you think parents can do if their child has been traumatized by pain, how they can support them and signs to look out for.
I think to me, yes, there's always room, and it's exciting, right? Because a lot of what we don't have the information, like every parent, like knowing this stuff that we're talking about, especially for parents of kids with chronic illness, like they don't, why would you know that? Like I will have, when I would do diagnosis counseling, parents would say to me all the time, I should know this. And I'm like, why on God's green do you know this? Like that would be super weird. You weren't like, hey, I'm going to have a baby. Then when they're 5, they're going to get diagnosed with cancer and I should know how to handle that. I'm like, no,
Yeah.
you know how to handle this. This is super bizarre. Like you really, okay, this is a bizarro skill set that you're going to have to learn now. And I'm super sorry you have to learn this, but you do. So that's what I really just want to say to all those parents listening, like that you haven't know how to do this is totally normal.
Mm-hmm.
It makes so much sense.
Mhm.
And that's really what, again, we're trying to do with the foundation is use technology that it's available when and where you need it. Like, I don't think every parent needs to know how to handle a VCUG, but when they suddenly are in that position, we want to know, and we need to be able to deliver it to you then. We don't have time to do research for 16 hours, right? Like we just know it. But to that end, having those what we call corrective experiences are really powerful and huge. And so when I think we think about trauma, we think, and that really happens, that's a spectrum. So sometimes we use that word as a all or nothing, and it's really not. So that kid who is a little bit anxious and freaks out a little bit versus the kid who's like, pinching themselves and doing self-harm behaviors at the thought of doing things, or we're having to pull them off the ceiling practically. Like those are all levels that we want to listen to the behaviors of our kid and to see. This is also a time. So we even talk about in kind of our platform putting out that there's going to be a level that the things that we're going to teach them through this platform isn't going to be enough, that this is the time we want to bring in the psychologist. I always think that the child life specialists are first line of defense, because I think those in your profession are really good at drawing that line between sort of normal kid behavior versus, now we really are into a new zone that requires a different level of care. But I think one of the most important things that we can do is recognize that these are all skills, and to frame that as skills to their kids, and that when we don't have the skills, then we can't do it. And that's not weird. Like I could not play baseball very well. I do not have that skill set. Unfortunately, I don't have to play baseball anytime soon. So I'm solid. I don't need to learn that skill set.
Right.
But when we have a kid who has to learn how to do lumbar punctures or repeated blood draws or accessing our port or doing whatever that is, we have to learn that skill set. But that means that we have to be able to do things like make plans and acknowledge what is hard, right? To tell kids, I think it's one of the most dismissive things in the universe to have someone tell you something's no big deal. Well, second only to telling someone to calm down, which when I trained medical professionals, and I would like to state for the record that never in the history of mankind has telling someone to calm down actually resulted in someone
it doesn't work
down.
No.
Mostly it makes them ramp up because you're like, oh, you clearly do not get what is going on.
Right.
You think calming down is on my options list. Now, how to calm down is a whole different conversation, right? Like I want you to look at me and take some good deep breaths with me. And I want you to feel my heartbeat and your heartbeat and how they're going to be calm. Like those are actually calming things.
Right.
Telling someone to calm down. I was like, have you ever been in a fight with your partner? And if they said that to you, how's that gone? Has that been good?
Oh yeah.
No,
it's not good.
It's not good, right?
It's not good.
Nothing good happens after that. Don't do that. It's a bad idea.
If you take one thing from this conversation,
I'm like, free relationship advice, don't ever do that if you want the conversation to go up. But to be able to set up those, what we do, we call them corrective experiences or mastery experiences, and to recognize that what they are going to do is going to be tough, but they can do tough things, and that we're going to put together a plan, and that the people are here around them to support them to figure out how to do that. And that's okay for it to be a process. Like we know that like Jamie, like little tiny Jamie, that if we've been able to go back and, hey, do you know what we're going to practice? We're going to practice just going in the room. You're not going to get the cannula start today. You're not going to get an IV. We're going to go and practice, and we're going to have like a rocking good time and play and do whatever. Like we're going to just start associating that room with positive, good stuff. So that's good. And then we're going to come back the next time, and we're going to go the next step. We're going to do that. And then the nurse is going to come in and just wave high and take your, blood pressure, because we know that's no big deal and we're cool and we're good. So being able to recognize where our kids are. And by the way, that it is not a failure. Like my largest pet peeve of the language, like I'm a big stickler about language and how we use it, because when the words we use frame our experience. Okay. So like and on every big level. So like my kids are otherwise generally healthy kids. And so when we go to the doctor, I'm like, we get to go to the doctor and we get to get the magic medicine that's going to help keep us healthy. When we get to do something, that's good. When we have to do something, not good. Right?
Yeah.
It's so true. Right? It's so true. And thinking of those, and like, whenever I hear, and Katie, I'm sure you know this too, but whenever we hear nurses saying like, "Oh, it's me, I'm the bad guy," I always want to be like, "No, you're the helper. You are the good guy." And that's what, like in narrating care and anticipatory guidance of how we're walking kids through procedures, that's something that we just reiterate. The nurse is going to help you by cleaning. The nurse is going to help you by tying this tight rubber band. Yes. And that I wish we could give that gift to all nurses and techs and anyone that has to do anything physical to a child, that you should never paint yourself as the bad guy. No. Because you're the one that's helping.
Yes.
Well, and parents can do that too. You know, when the nurse walks in, this is the lady who's going to help you. She knows exactly what to do. They get to do that framing too.
Yes, exactly. So that's one of the things that we like to talk about, that is the comfort talk and healing language of how we present it. Like, hey, this could be tough, but this is going to be an opportunity for us to figure out how we do this and make it easier and good, and something that you get to feel good about. Because that's when we have like this whole failure language of, well, if we can't do this, then this is bad. Or when we started crying. I mean, I get this even with the kids I work with needle phobia, and a parent will come in and say it was a total failure. And I'm like, okay, what happened? And they're like, well, they used all the tools and they were calm going in, and they sat there and they waited for them to come in. But then right before she did the poke, they started crying and freaking out a little bit. And I was like, actually, that's like a raging success.
Great.
Okay. Like this is a kid who you couldn't get out of the car and now is sitting there. And how great that we went from here to here. And that's amazing, right? So like anything where we're seeing this as a victory, you're like, that was awesome. You didn't hit me one day. Congrats.
Exactly. No bites.
No one got bitten. And it is, by the way, and that's like a sincere, like, you know, we kind of laugh at it, which it is, but it's also like, it is hard. We are talking about touching on something so primal. Like when we talk about pain, it is our most primal instinct. And when I train providers, that's what I talk about. I'm like, guys, like, they're like, why is this tough? I'm like, because literally this is how we're programmed. This is literally why we've survived as a human species, is paying attention to pain. And so we have to have a super good reason to not do that. And so actually, you know, Katie, getting back to your question a while ago, I think the other thing we need to do is assure people of safety. Like that what is going to happen, it might be uncomfortable, it might be hard, but that signal in your brain saying danger, that we don't actually need, that you're safe, that we're doing this to help you get better or stay healthy or whatever the reason is. But that alarm bell going off is normal, but we don't need to pay attention to it, because it turns out that you are safe and you are okay. That speaking to that primal little screamer in the back that's going off right now is really so key.
Oh,
I love that. That's good. That's good. You're good, Doc. You're good.
She's so smart. She's so smart.
That's why I've wasted my life for 25 years. It's good.
It's true. And that's one of the great things about, like one of the first thing when I know Jody years ago from Hole in the Wall Camp. But when I reached out to her about a year ago, more recently, a year ago, it was professionally, because I know that Jody is a pain, psychologist and a genius and has done this work for years. And I needed help with kind of tackling this from an institutional level. And one of the first things that I looked at on the Meg Foundation website was just the videos of your brain is in charge of your body. You're the boss of your brain. And that feeling, it's all about empowerment of you have control to think about this and to think of, yes, this is what your primal brain is telling you this, but this is actually how we could handle it. And then take, a step beyond that is empowering the parents to help their kids do that. And there's so many different tools on the website that are really great, and just giving tools right in the hands of parents. And I know that from a child life specialist perspective, and Katie, I'm sure you can relate to this, it's so nice to have somebody else besides us being the ones to be like, hey, wait. And we really need to put these in the hands of parents that these are the folks that need it. And they have a voice that, quite frankly, is much more powerful and should be much more powerful than ours as any staff member. So
I agree.
It's some pretty great stuff.
Well, and that's what focus is for parents. And that's what, if they go to some of those, like Be the Boss of Your Brain video, is really about teaching parents and kids. It has what we designed it and what we like to call the Pixar effect, which is what parents get out of it and what kids get out of it.
Yeah.
Things, right? Like Pixar movie, you watch Up, for a parent and a kid, you're both sobbing for different reasons. Yeah.
Right.
But to be able to have that framework and language, to understand, as I tell people all the time, especially when it comes to things like pain, I said, we can't control something we don't know how it works. And so I want you to understand how it works, because then that opens up all the opportunities for how we can change and control that experience.
And guess what? Parents can use it on themselves too.
Yes.
That's the best part, right?
Isn't it amazing?
You could use it on your spouse. Prepare that. I mean, there's just a lot that we can do to make the world a better place.
It's true. It's so true.
How can we learn more about the Meg Foundation and follow along with what you're doing and the tools you've developed and are going to?
Well, I'm glad you asked. That'd be great. So we do have a really active social media, and we, which we have our website, and we're actually in the process of revamping that to make it even more simple to kind of search for tools specific to what you need. Right now, all of our resources are organized by age. So you can go in if you're having a baby, a toddler, elementary school age, teens and tweens, different for kids with chronic pain versus kind of acute procedural stuff. So we've tried to organize it, and we're in the process of revamping it to make that process even more clear. We've launched a few tools. We're going to be launching even more. So social media is a great way to kind of, because it's not like you're going to go back and revisit the website every 8 seconds. So social media is a really great way. One, we put out a lot of kind of quick tips on there. We also put out, like one of our goals is to translate sort of the academic-y speak to like normal human language, as I like to call it. And like, what's the take home for what I could do with this? You're like, I'm not really so interested in interesting theoretical fun facts about pain if I'm a parent. Like, I want to know, what do I do with my child right now?
What do I do?
I don't care. You two go be nerdy about that, but I want to know what I do, right?
Yeah.
So we like to translate a lot of that latest research to what it would actually mean for a kid and a parent. But the other thing we do is we have all of our new tools. So right now, like we have a lot of infographics on comfort and creating comfort during procedures and whatnot. Especially, we've released a bunch of stuff about COVID testing and nasal swabs, which wasn't really a thing a year ago, but now certainly is. We have an interactive chatbot that actually interacts with kids. So there's a little character named Spud that asks kids questions and puts together their own comfort plan for how they want to cope and manage and handle. And then they put in a parent's email address, and then that plan gets emailed to the parent about what their kid wanted to do for their coping plan. And then we also put in some other resources in there. We're about to launch one in hopefully another week or so right here before the end of Pain Awareness Month. That's actually for putting comfort plans for pokes, where again, you kind of have your kid go through it. They decide which coping skills they want to use. It's personalized to what they want to do, but it very much puts forth this idea that's so important. And again, that trauma piece that you were talking about, Katie, that they are given power and control, that they have ability. It's not just, I have to go and be at the mercy of these adults, some of whom I know, some of whom I don't, some of whom I trust, some of whom I don't.
Right. Yeah.
That you have power and control. And then the Super Meg platform, which is a really cool interactive tech platform with like 3D animation and video and goes through all this, which is really for parents. Kids will benefit too, but it's really about how parents can advocate successfully in medical care settings for these things, what they can say, what they can do, what can happen beforehand. And that's also designed around like, is this procedure happening in the next 5 minutes? Is it happening in the next few hours or the next few days? Because that obviously changes
It makes a difference. Yeah.
what they're able to do and how they're able to execute. So, but yeah, the Meg Foundation website is a great place to start, and following us on social media is a really great way to just get those pushed out to you, that you don't have to feel like you have to, check back and see those things.
Awesome. And what's the handle on Instagram and Facebook? Is it just the Meg Foundation?
It is, yeah. So Twitter is just at Meg Foundation. Facebook is Meg Foundation for Pain, and that's the same for Instagram. So Meg Foundation for Pain is a great search. And yeah, so all of our stuff, we also want to mention that our stuff is available in often multiple languages. We're recruiting like this great team of clinicians from around the world who are doing Spanish, English. We actually have the Be the Boss in Your Brain video, which I'll mention is I actually did for Stanford Children's Health, but it is publicly available for anyone to use in any settings. There's hospitals in the UK and Australia and all over who are using it. But
soon to be a Nova.
Awesome.
And we're doing it's in English and Spanish. It'll soon be available in Mandarin or Arabic, Thai, and a few more languages.
That is awesome.
So we use it in like some refugee camp settings and disaster relief settings. Some NGOs are using some of these techniques for kids in disaster settings as well. So a lot of the things we have are available in multiple languages. And they're all, I just always want to emphasize, I know parents are like, of course, but sometimes clinicians and organizations, one of the reasons we exist is to make this all publicly available. So they are not, institutionally branded. Anyone can use them. There are no fees for using our tools. This is all meant to create mass access when and where parents and families need that.
I love that. That is so cool. Well, thank you so much, Jody and Jamie, for hanging out with us on the Child Life On Call podcast today. This was a really fun edition. I think it's going to resonate with a lot of parents. You guys have both given a lot of tangible tools and tips, and I can't wait to go to the Big Foundation website right now and see how I start using this in my practice. So that's awesome. Thank you so much.
You're welcome. I just want to say to your the parents out there, please feel free to contact us if we can be helpful or useful. And we're also really looking to meet their needs. So we spend a lot of time talking to parents about what they're looking for and where the holes are, and because that's what we want to fill. So if there's things that you don't see or that you wish existed, please tell us, because that's what we have the freedom to work on creating that.
Thank you so much for tuning in to the Child Life On Call podcast, and to specifically Jody Thomas Dr. Jody Thomas from the Meg Foundation, and just all the work that they're doing to make lives a little bit easier for kids who have to go through pain. And thank you so much to Jamie for your perspective and your guidance and your stories and just your unending attitude that constantly promotes positivity in a way that makes us laugh. If you haven't already, please subscribe and then rate and review the Child Life On Call podcast wherever you find your podcast. So if sometimes you listen on Spotify and other times it's Apple Podcasts and then it's Google Play, if you can rate and review at all those different places, it really makes it easier for other parents and professionals to be able to find us. Follow along with us on Instagram, Facebook, and Twitter. And so you can see the latest happenings about what's going on, what the episodes are about, and just a lot of resources and education for parents and children. So thanks so much, and I will see you guys next week.